Great. Thank you, Ashley. Thank you, sponsors. Again, number 18. I can't believe it. Phil, it's just like flying, isn't it?
Amazing. That's
Yeah,
almost 2 years, Rob.
I know. I know. Just a couple more. But we have great guests tonight for us, everybody. I'll let them each introduce themselves. Phil, do you need to introduce yourself?
Oh no, I'm Phil Page, Baton Rouge, Fran U, DPT. Glad to be here. Thank you.
Great.
Move
Timmy?
along.
Timmy, tell
Tim,
everybody a
Ty-
little bit about yourself.
Tim Tyler, past president, 6 years with Rob Mansky as my vice president,
VP?
vice president, and a proud employee of the Nicholas Institute of Sports Medicine and Athletic Trauma in New York City, and employee of professional physical therapy in New York and the Northeast.
Great. Thanks, Tim. And then our very special guest, Dr. Stephen Nicholas. Dr. Nicholas, tell us just real quick, briefly about yourself.
Hi, guys. My name is Stephen Nicholas. I'm an orthopedic surgeon at Lenox Hill Hospital, the director of the Nicholas Institute of Sports Medicine and Athletic Trauma. And I am a big believer in the interaction and interrelationship between therapists and orthopedic surgeons. It's always an honor to be involved with you guys and to be here. So thank you for having me.
You're welcome. Thank you very much for joining us. And before we actually start these articles, Dr. Nicholas and I were talking just a little bit before we started. So I'd like to ask him a couple questions that are really maybe more personal than are related to the articles that we talked about. Dr. Nicholas, could you, I know your father was a great surgeon. Could you tell us a little bit about your father and, you know, his impact you had on, or the impact he had on your life, and maybe, you know, how that changed your or made your decision for you to get into orthopedic surgery?
Well, there's so much to say. I could speak the whole time about this, but let me just
Oh, I bet.
quickly. My dad was an orthopedic surgeon who had operated on President Kennedy. And in 1960, Harry Wismer, who was the doctor for the owner of the New York Titans, invited my father to a game. And he went to the game, and a defensive back broke his neck at the game and went down. My father ran down the field, tried to take care of him. No ambu bag, no spine board, nothing on the sidelines. The guy died. And my father was a trauma surgeon, a master surgeon. Said, "This is ridiculous. We have to treat this like a battlefield. We need to have doctors on the sidelines at every game, and we need to have sports medicine." And that's really, even Don O'Donoghue said he was the one who really popularized sports medicine and was known as one of the fathers of sports medicine. So he came to be the doctor of the Jets at that point. And 5 years later, Joe Namath was signed by the Jets. He operated on him the day he signed with the Jets. He operated on him, and I was his roommate. I had my tonsils out that day. And Joe then subsequently made his fame, had a bad knee. My father invented the first knee brace of its kind, the Lenox Hill knee brace. Put it on Joe. Joe played in the Super Bowl, and then kind of the rest was history. And when I was a kid growing up, he was a doctor for the Knicks, Nets, Jets, Islanders, Rangers, Yankees, and Cosmos. So Pele came to my soccer practice. Mickey Mantle came to my Little League practice. Joe Namath and Don Maynard, we played two-hand touch football in my backyard. So who wouldn't want to be a sports medicine doctor after that experience as a kid?
No kidding.
New York. Here's the sounds of New York in the background. You can hear the sirens.
That's an incredible story. That's unbelievable. I bet you're right. I bet you could go all night with stories, I'm guessing.
Yep.
Dr. Nicholas, tell us, you were telling me about how you thought that like the art of communication between doctors and therapists is so important, and how it's almost kind of like a lost art. Can you speak to that just a few minutes before we get into the articles?
Yeah, so at the Nicholas Institute of Sports Medicine, we have a weekly conference which involves physical therapists, researchers, PhDs, orthopedic surgeons, orthopedic fellows and residents, and physical therapists from throughout the city. We have these core lectures, and we're all interacting with each other, get to know each other. When we have patients, we speak to each other. Hey, this is a little bit unique. Let's slow this cuff down. Let's do something on this ACL. I think we have trouble getting the extension back. And the interaction provides such great care for patients. And unfortunately, we've gone away from calling the therapist calling the doctors. My therapist had my phone number, my cell phone number, so we can speak about the patient. And I think that's an art that we need to make sure is preserved, because it ultimately provides a much more effective way of taking care of patients.
Timmy, you've worked with Dr. Nicholas for quite a while now. Tell us, maybe give us the inside scoop of why he's so great to work with.
He's so great to work with because he is understanding, compassionate, and he gets therapy, so it's not his way or the highway. It's if you suggest something, he'll question you about, is there evidence behind it, but he won't say, we're not doing that. He listens. He's a good listener, to be honest with you, and a great friend.
Great. That's fantastic. All right. You guys want to hit the articles?
Go ahead.
You tell
Ready?
Timmy
Okay.
we're not doing that. I must say, when we play golf together, I tell him we're not doing that quite a bit because he likes to hit his gap wedge 100 yards. He can only hit 50 yards. I won't let him hit the gap wedge from 100 yards anymore.
Phil, they may start before you and Timmy get going.
I'm gonna let them go after.
Yeah.
It happens every Monday and Thursday in the office.
All right, guys. So our first article: effective repetitive corticosteroid injection on tennis elbow surgery. Okay, this is by Dr. Chung-Soo Ha and his colleagues, I guess. The objective of this study was to determine the effect of the number of preoperative corticosteroid injections on postoperative clinical outcomes. Their hypothesis was the number of injections before surgical treatment doesn't affect postoperative clinical outcomes. It's a case series. They did a retrospective review from January 2007, December 2019. 99 patients had surgical treatment for lateral epicondylitis with the modified inertial technique. Let's see, the 99 mean total number of injections was 4.37. Total duration of non-operative treatment before surgery is 25.4 months, with a huge range, 4 months to 124.8 months. Mean postoperative follow-up period 42.8, range of 12 to 110 months. For all injection numbers, clinical scores showed significant improvement in VAS, pain scale, DASH score, Mayo elbow score, grip power, and wrist extension power after surgery. And the regression analysis showed that the degree of improvement according to injection number was not statistically significant. Okay, so the number of preoperative corticosteroid injections didn't appear to affect postoperative clinical outcomes in patients with lateral epicondylitis undergoing surgery. And Dr. Nicholas, my guess is, I don't know this for sure, but this was published in 2023, so this year. Was this maybe part of something that was they were looking at simply because of, those last maybe 5 to 7 years, there's been multiple shoulder studies showing that if you have a corticosteroid injection in your shoulder prior to having surgery within 3 months, 6 months, or something like that, people typically do a little worse. Do you think that's like the genesis of this article, why they wanted to look at that?
No, I don't think so. I think the shoulder and in these studies that say you get an injection, you have to wait 3 months, are indicative of increased incidence of infection. So
okay.
I think the interesting thing about the studies is they compare patients who have 1, 2, 3, and 4 corticosteroid injections, but they don't compare patients who have 0 corticosteroid injections and how those do who have surgery compared to those who had multiple corticosteroid injections. And the answer might be 1 is just as bad as 2 and 3 versus it doesn't matter how many you had. Maybe it matters you had any. And I think that's the biggest deficiency in this study. Additionally, many studies have shown that there's an increased incidence of post-lateral shoulder and elbow instability when you have these corticosteroid injections. And they're given a lot of times by internists who are really not as familiar with the anatomy. And so if you get a little more distal in the elbow, you get the ALL and you get post-lateral corner instability. You can affect these ligaments in a negative way. And so I think that it's hard to clump them all together. Was a steroid injection given by an orthopedic surgeon? Was it given by a primary care doctor? Or how does that compare to somebody who had no steroid injections? In my practice, I almost never give steroid injections, almost on anything. My rule of thumb is if you're playing in the Super Bowl or your daughter or son is getting married, I'll give you a steroid injection. If not, I'm going to do something less likely, like maybe PRP injections. And in my practice, the need for a surgery has diminished quite a bit now with the use of PRP for this particular problem.
Yeah, you use it quite a bit now.
I do. Listen, therapy is always the mainstay. And I think that 95 to 98% of patients get better with physical therapy. And I encourage everybody to start physical therapy first. And then the next line of treatment for these patients in my practice is a series of 3 PRP injections. I would prefer to operate on the patient than give them a steroid injection.
How long do you spread out the PRP injections?
They're given a series of 1 per week for 3 weeks.
One a week for 3 weeks. Okay, good.
And therapy is usually started after the 3rd week, and I do that for about 2 months. And I'd say 90% of the people we inject, and we've looked at this, get better with the PRP and therapy. But even before that, that's of the people who come to need the PRP. But 95% of people getting better with therapy before we go to the needs for PRP.
So if these like this, the preoperative time or the time that they were in therapy was there was such this huge range up to like 124 months. Why is it taking so long to resolve these? Are these people just not coming in, or are they getting inadequate therapy? Why does it take so long for it to resolve?
Well, in my practice, a patient would never wait that long to have.
Yeah, that seems like a long time.
So I'll wait if I can 3 months. 6 months would be the most, and patients are fed up. They either want, with 3 months, I usually do the PRP, and if that doesn't work, a month and a half after that, 2 months, then I'll do the surgery. But I used to do probably 40, 50 inertials a year. It's now down to about 5 to 10 a year.
Oh, wow, that's hardly any.
I think that's true of the PRP. The population of patients seeing me with lateral epicondylitis is the same. It's just not needed. Surgery is not needed as much.
Well, that's ever since the Tyler twist came invented. Come on.
Was that when it turned around? That's
part of the 95%. Never need even the PRP.
One of the things that I didn't really like about this study was that it was a level 4 case series retrospective. A prospective study would be a much better way of determining the true effect of this. But when you're looking at this, as Dr. Nicholas said, there's so many factors. Who gave it? What did it do? We really need this prospective type of study to look at this to really make a good, accurate, I think, conclusion about the number of injections that we need. But retrospective just isn't the way to go to make a good decision.
Yeah, and as you mentioned, no control. I mean, there was no one that had no injections. Dr. Nicholas, can you describe the inertial and is it pronounced Patrone grade? Patroni grade? It's like a grading system they used in this to look at, I guess.
Inertial procedures done. What happens when you have tennis elbows, you get angiofibroblastic dysplasia. So that is the normal ligaments are lined up, and the collagen fibers are lined up in parallel to each other, and you can see them quite readily. When you have angiofibroblastic dysplasia, you get in patella tip, you get in the rotator cuff, and you get in the ECRB. The extensor ACRB has ingrowth of vascular tissue, disorganization of the orientation of the fibers, and fibroblasts that infiltrate the area. And so when you look at it, it looks like a fish meat. It looks like a very shiny fish meat. And so what we do with this operation is we go down to the common extensor tendon, and we split between the ECRL and the extensor digitorum communis. And as you open that up, the ECRB is behind that, and you can see the fish flesh appearance. That is ellipsized out, and the tendon then sutured, in my practice, back to itself. I don't reattach the bone because we don't detach it. We actually just split it, open it up, ellipsize the tissue, and close it back up. And our success rates are very high in that.
Good stuff. Good stuff. Hey, Tim, we have someone posted a question here. The current, I'm not sure if they mean the current Tyler twist study, the one that we're going to talk about in just a little bit. It says the current Tyler twist studies show good outcomes and decreased pain. How is the therapy regimen different from the previous study published a few years ago? And I don't know who it's an anonymous attendee who
I want to. We'll get to that because I have a problem with that study. So
yeah, let's hold it off of that until we get through.
Hold off on that one. Okay.
Yeah.
Okay, we'll come back to it. Dr. Nicholas, tell us about blinded, because the study talked about blinded injections versus ultrasound guided. So I know you said you don't do very many injections, but if you do, and when you did you do them ultrasound guided versus blinded?
I do ultrasound guided injections many, many times. I feel the lateral epicondyle has very distinct anatomic insertions. You can feel the epicondyle is subcutaneous. You can identify it with your finger quite readily, and you actually could walk it up with your needle. So I don't necessarily, do you think you need to do an injection? Sometimes New York requires it in order to get reimbursed for it, so we end up doing it. But I think for this particular problem, you don't need a documentation. Same way you don't need it to inject the knee. Now, many studies have shown that if you're trying to inject the knee, 20% of the time you might miss the knee when you're doing a steroid injection. But after doing ultrasound guided steroid injections in the knee, and after my 1000th injection, and every time we documented in the knee, we stopped doing them in the knee. So you need them in things you're worried about getting inside. So maybe shoulder, going into the coracoid process, things like that. And this, I don't think you need it, but again, we have done many of them.
In the elbow, yeah. Is it parts like, is it like it's so superficial?
It's so superficial. The bony landmarks are palpable.
Yeah.
I think you need to do it.
Yeah. I had a question here about like looking at so these people, you said, I think what you said kind of matched the extent of your conservative treatment kind of matched what the second study we're going to talk about was, where they said they recommended conservative therapy for maybe 3 to 6 months before recommending surgery, which I think is kind of like you described.
Yeah.
Have there been go ahead. I'm sorry.
3 months therapy. If that doesn't work, I introduce the PRP. I give it a month and a half, 2 months for that to work. And then probably 5 months, I recommend surgery if they don't get better.
Yeah. Are there any studies looking at,
depending on the demands of the player?
Sure. Are there studies looking at early surgery versus waiting later and to see like do outcomes, if you do surgery earlier, will their outcomes maybe be better because maybe they haven't lost as much strength or motion as if you let it go chronically for the 124 months or whatever?
Well, I think the strength is usually pretty good because they're doing therapy during that period of time. And I think the results of the late inertials are quite good. So to compare them, really wouldn't, the end would be too high to notice the difference between the two.
Okay, so it wouldn't probably tell you a whole lot. And then the other thing was, so I don't know how you would probably wouldn't be able to answer this because you said you really don't do injections anymore. My question was, is there actually an optimal number of injections if you're going to inject someone's elbow? I mean, this study showed it didn't matter how many, they seemed to do okay. What is too many? What's optimal? What's too many?
Again, what I said was one.
Yeah.
What I said was one. I think the permanent change that's affected by cortisone on tendon insertions, most of these studies show very good early results with these steroid injections and poor long-term results. So they deteriorate over time. The same studies have not shown that to occur with PRP. It either works. If it works, it's usually long-term. If it doesn't work, then you can always do the operation.
Yeah, if it is as an alternate if you need. Okay, we got a couple other questions here. One for you, Dr. Nicholas. From Becky Keller, why do you choose 3 PRP injections? In my experience, most insurances don't cover PRP, and she has that they're $500-600 a piece.
Most insurances don't cover it, and the studies we've done have shown that 3 is what works. We did 1, and people used to come back at 2 and 3 months. So see if the 3 works. We'll be publishing that because we have a database of over 500 of these we've looked at.
Nice, good. What PRP injection is? Here's another anonymous attendee. PRP injections are typically not covered by insurance. What do you tell a patient if they can't afford the PRP injection? What's your next option? We
have a lot of opportunities where we provide care pro bono for patients. So we will try to work with them on that. Most people that can't afford it. There are some institutions in this country that charge $1,500, $2,000 for a PRP. I think that's unconscionable. But I think you can, probably reasonably provide PRP for most people. And if they can't do it, then, there's other options. You can do a needling, which used to work quite a bit on patients, which was no injection whatsoever. But again, I prefer doing that over a cortisone injection. Good. And the other thing, PRP will be covered in the next 6 months to a year. The data is far too compelling for them to reject it.
Good. Phil, Tim, do you guys have anything before we move to number 2?
No, you're doing autologous PRP, doc. You just bring it from them, and how do you make the PRP for the patients?
We draw their blood.
Yep.
We spin it in a centrifuge.
All in office. Yep.
Yep, on office, 10 minutes later, re-inject it.
Beautiful. Beautiful.
And the thing, if you're going to do that, is I put a bag of ice on them. And the reason I do that is I had PRP done in my Achilles tendon. And there's nothing more painful than someone stick a needle in the back of your Achilles tendon without ice on it. So the first one I did it with no ice, and then my partner, Dr. Lee, did it. And the second one I iced it so I couldn't feel anything. Much better. So I have some compassion for my patients.
There you go. Nice. All right. You guys ready to move to number 2?
Let's do it.
All right.
Absolutely.
Is there any difference in clinical outcome between open and arthroscopic treatment for tennis elbow, a systematic review and meta-analysis? So the aim of this study was to determine the clinical outcomes of the 2 techniques by quantitatively synthesizing the data. They looked at searching PubMed, Embase, Ovid, and Elsevier databases between January 1995, studies between 95 and April 2022, with a minimum follow-up of 6 months. Quality of each study was investigated using the Coleman methodology score, which Phil, you're going to talk about later, I think, in great detail. They found 1,411 elbow patients in 1,392 patients who underwent release and debridement for tennis elbow, 693 open, 718 arthroscopic. Improved clinical results were achieved after treatment with either open or arthroscopic treatment. Surgical success rate was 95.6 in open versus 92.4 with arthroscopic. Complication rates were 2.2 for open, 1.5 for arthroscopic, so a little less arthroscopic. Patients who had undergone arthroscopic release seemed to return to work earlier, 5.3 weeks versus 7.1. And of course, as every good study says at the end here, to draw more definitive conclusions, more high-quality long-term follow-up randomized controlled trials are needed. We've never heard that one before, have we?
Probably a good idea in this particular circumstance.
Yeah. So what do you think of that study, Doc? Do you have anything you want to start with?
Yeah.
Open versus arthroscopic.
Well, if you look at the average incidence of complications of elbow arthroscopy, it's 4.5%. So I find it interesting that all these studies show that incidence of 2%. So it's not consistent with literature.
2.2 and 1.5.
Right. And the studies done on elbow arthroscopy show neurologic consequences to it. So, I think that, I think the arthroscopic and the open technique both work very well. I think that the elbow arthroscopy does bring into it some complication rate. And I think that if you're going to do it, you have to have a sports medicine specialist who's very facile with elbow arthroscopy. And you need to do more than 15, 20, 30 days a year. So I think that in most doctors' hands, opening the tissue is more effective. The other thing is when you do open it and you incise the interval between the ECRL and the EDC, and you take out the ECRB, then you sew it back together. You don't leave that gap. When you do it arthroscopically, actually you're leaving a gap. So I think that, because we do measurements of strength and we're not finding a difference in the strength measurements, doesn't mean there's no difference in strength measurements. It means our measurements are not measuring the strength deficits. And I would put to you that if you did an eccentric strength test on these patients who had the arthroscopic, you'd probably find an increased incidence of deficiency.
Well, that's the point, Doc, is they didn't do eccentric, right?
Mm-hmm.
And that's the thing is when you look at the outcomes of these studies and they're doing like concentric, isometric, whatever,
If that,
look at the right outcome.
Yeah, if that. Sometimes they don't even look at those, Phil. Sometimes they're just looking at pain scores and outcomes, patient report outcomes.
Clinicians need to understand is that these outcome variables that are measured are just not telling us the true story.
Mm-hmm.
Or the full story. Yeah.
And
so
if you also look at the cost effectiveness of this, the cost effectiveness of doing a scope, you're paying for the sheath, you're paying for the shaver blade, which runs about $110. You're paying sometimes for a second blade. It's more expensive to do. And I think in today's day and age, you have to consider that as one of the reasons or things you take into consideration before you make the decision to do it.
How do you decide which one you're going to do, Doc?
Well, I did arthroscopic for about a year when it came out, and I didn't see a major advantage. It took longer, and it brought with it the risk of problems with an elbow scope. And so I do the open technique. For the first elbow scope I did in practice, the patient came to see me 1 week later. It was a pretty extensive elbow scope, but with a wrist drop. And I was, oh my God, this is it. My practice is over. 2 days later, he called me, said his wrist was back and everything was fine. But, you know, it makes you think about things. I've done tons of elbow scopes, but it makes you think about things. Anytime you bring something to possible complication rate, you have to consider if there are other options that are safer.
Yeah, maybe. So this study, according to them, 90% do you think this is true, Doc? 90% of the patients that have these issues do better with conservative therapy. So in reality, then what that's saying is that really only 10% of these people need surgery. Does that sound about right?
It's even less. I said before, 95% don't go to
do well.
Don't go to surgery. Yeah.
Yeah.
And that number's increased from 85% with the Tyler twist, certainly. And
there you go.
and maybe PRP with that. Okay, Timmy.
Yeah. Hey, Rob.
Yeah.
I have the privilege of working in the same office with Dr. Nicholas, and to listen to him explain this to the patient is very enlightening. And would you rather have a scope where I'm putting a camera in there, or would you rather have me make a small little itty bitty incision and see all the necrotic tissue there and take it all out and then sew it back up? So which would you rather have is the question, and it makes a lot of sense, doesn't it?
Yeah. When did elbow arthroscopy like hit it really start, Doc? How long ago was that?
Oh, I've been doing it since I was in practice 30 years ago. So
okay, quite a while ago. Yeah. It's not like anything fancy new.
But again, the most important thing to consider is most doctors don't do a lot. So, you know, if you're going to a guy who's doing 1,000 of these a year, I don't think it matters what you do. But most doctors are not doing that in those numbers. And, you know, you got to do what is best for the patient in your hands. So I think most people are going to err towards doing open.
Yeah. So some of these studies in this showed that there was actually, with the open, and maybe you can explain why you think this is, with the open, there was actually greater pain relief with the open than with the arthroscopic. Do you think that's because of, again, like Tim was saying, what you can see in there and what all you can do changes it that much?
So in my practice, I've revised 4 or 5 open arthroscopics to open, and you go in there and you incise there and you look at the interval and it's not touched. So maybe this is done by people who are not as experienced, because a good experienced arthroscopist, we know exactly where to go and how to do it. But sometimes they miss the tissue. And if you miss the tissue, you're not going to effectively reduce the pain. Or if you just take part of the tissue out. So that's probably why.
Great point. That's what I was wondering. That's just the answer I was asking for. Phil, go ahead. Did you have something?
Yeah, I got to jump in on this one, because to me and to Timmy's delight, this is not a great systematic review and meta-analysis. And the reason is that they included way too many case series and level 3 cohorts. This is a scoping review that is not eligible for a meta-analysis. A meta-analysis should be randomized controlled trials that compare 2 groups, with and without, whatever. What they've done here is they've made more of from a level 1 to a level 4 inclusion criteria, which is not the way we should be doing our meta-analyses. They really should be stuck to randomized controlled trials. So I take this with a grain of salt. I don't think that this was a really good, a well-controlled study in terms of what they included in their studies.
I agree with you.
Yeah. Timmy, you have anything to add?
Yeah, that when he gave me 3 weeks to get these articles together, he didn't tell me to choose good articles. He just told me to choose something to talk about.
No, but Timmy, that's not the point of the journal club, is to actually have bad.
I know.
I shouldn't say bad articles.
Yeah, come
on,
Phil.
great articles. So we can tell the listeners what to look for. That y'all need to look at the fact that when you look at the inclusion criteria, they're including case series. You can't do that with a meta-analysis. I'm sorry, you just can't.
Absolutely.
And you know, unfortunately, in today's day and age, everyone's looking for publications.
Exactly.
It's written down. It doesn't mean it's necessarily something that's accurate. And so, again, the first thing I said was to 1.2% incidence of complications during arthroscopic surgery in the elbow, when the national average is 5%.
Right.
Yeah.
Mhm.
And that's what I want. One of the reasons why we love doing Journal Club is to educate our consumer clinicians who don't have a good grasp on what good research looks like. In the old days, we used to be able to go, oh, I'm just going to trust the JBJS studies and the AJSM studies. Nowadays, with these predatory journals, I'm not saying this one is, but there are so many out there that are open access and all that kind of stuff. Now, you just have to look at this, whether this is a good journal or not, doesn't matter. It's the quality that matters. Whether it's a predatory journal or not, this is not a great representation of a meta-analysis.
Bill, they only looked at studies that had a 6-month follow-up. That's got to be a little problematic, doesn't it?
Yeah, of course. There's lots of problems with this. And but to Doc's point, what happens is, and Timmy, you're going to back me up on this, people publish these because they're level 1 evidence, everyone cites them, and everyone gets credit, and they're easy to do. The hardest part is doing these clinical studies that were made up with this. But even these case series level 3 and 4 studies, those are relatively easy compared to a level 2 study of a randomized controlled trial, which takes more time, takes more money, all this stuff. But there's so much waste in research right now, and it's really just about getting a publication. And as our good friend Timmy Bob Top used to say, every article has a home.
Yeah.
It just costs you some money.
We won the Grant Award for a randomized prospective study comparing double row and single row rotator cuff repairs, which took us 2 years to get the study done, because can you imagine New York City trying to get people to randomly operate?
I think it's more like 5 years from the whole start of it.
It was difficult, but it was a valuable study, match cohort, randomized prospective study. That's what you need to really answer this question.
That's right.
Yeah, that's not what this is it? Yeah. Yeah. So Phil, are you going to skip the Coleman methodology score question?
Oh no, I can go there.
Did you see what it is? Did you look it up to see what it is?
I did actually. So you guys, Timmy, you seem to like this Coleman methodology for some reason. I don't know why. But
I didn't know what it is. I had to look it up too. I had no idea what it is.
I'm gonna get a headache.
Well, I've never heard of this, but here's what I love to do. I like to go back and find it out. So apparently in 2000, B.D. Coleman out of Australia apparently did a study on patellar tendinopathy surgeries and made up this Coleman methodology. I actually have the paper here. And all it was just this criteria that this Dr. Coleman kind of made up that said this is what good surgical studies should look like in terms of methodology. And what's cool is, as you go into the study, it says it correlated the methodology score with success rate. To me, that's BS. Totally. How can the methodology of the study relate to the success rate of a surgery? The methodology of a paper tells me about the outcome of a surgeon. It blows my mind.
Yeah.
So I don't like this. And the interesting thing was, Timmy, about this study, I'm not picking on you, Timmy, by the way, but the Lee study actually said that they did the Cochrane bias, which is what they should do.
Right.
And they reported on it, which sucked in terms of allocation and blinding. But I mean, that's why it's all level 3 and 4 studies. And then they say that they weren't methodologically. When I did like a PubMed or a Google search on Coleman methodology, lots of surgical studies use this methodology, but I can't find any validation, no reliability. I can't find anything. It's one of those tools. You're just playing with this number, and it doesn't mean anything to me.
Yeah, I looked also for a validity study on it, and I could not find it. So
it's still a tool. It's okay, but
no, it is. Yeah, but it's apparently got its limitations. So
more than I think the value of it. It doesn't tell me, because Timmy says, "Well, the range is this." I'm like, so what? What does that mean? It means nothing to me. The number means nothing. Like if you went to a Cohen's D, what's the effect size? A 0.2 is small. Get it. 0.5 is moderate.
So what? So Phil, what they give points for? I mean, what kind of stuff are they getting points for?
What Coleman talked about is study size, mean follow-up, type of study, diagnostics, certainty. I mean, he just made this stuff up. So how can you just make something up and then everyone use it? No one researches it. Now, I'm not saying it's not out there.
It.
I couldn't find it. And I'm not a big fan of this Coleman methodology.
Right, Doc.
But Timmy's, I'm sorry, one more thing. But to Timmy's point, the Coleman methodology isn't the problem with this study. It's the fact that they use case series.
There's a bigger issue. Bigger issue. All right, Doc, we got another question for you. I think this is for you. There seems to be discrepancies in how to treat lateral elbow pain between physiatry, sports medicine surgeons, orthopedic doctors, hand therapists, and hand and wrist surgeons. What are your thoughts about a wrist splint for 3 to 4 weeks to rest the ECRB wrist extensors upon acute onset?
I think that's something I do quite frequently. Someone's got a lot of pain. I'll rest them, put them in a wrist splint, actually put them in a sling also, before they get kind of resolution of some of their symptoms, and then we start physical therapy. So I don't think that's unreasonable. I think you have to individualize each patient. But if you come with a whopping lateral elbow pain, I'm going to put you in a splint and a sling, give you a couple of weeks off, to ice, give you some home stretches and stuff like that, maybe a rubber band for eccentrics and stuff, and then have you work with a therapist after we get the initial acute pain under control. So I think most people, hand and elbow surgeons and orthopedic sports medicine surgeons, agree on the technique for surgery. I think that most will agree that it's inertial is the way to go. Some will do it arthroscopically, but most will agree that the inertial is the way to go. As far as rehab is always individualized, always. There's no cookie cutter. So if someone comes with acute exacerbated patella tip syndrome, you don't go right into physical therapy. It's ice, stretch, massage, the extension brace, let it calm down, and then see what you can get with therapy.
Yeah, I think that's it's a really underutilized, I think, in a lot of places, just to let something calm down. I mean, it's just like it's like people think there's something wrong with actually, I mean, it's like we've gone the completely opposite way, where we think we got to be doing something constantly, stressing it constantly, when in reality, a lot of times you just need to back off and just let it calm down.
And I think if you reasonably speak to a patient the way you just did, say, okay, look, we're going to put it rest for 2 weeks. Then there's this underlying, damage to the tendon that we have to actually strengthen tissue around it, stretch tissue, and then do modalities to kind of control some stuff. But we just got to explain to the patients, they need to leave with a plan. That plan can be anything you want, but they need to walk out with a plan. So they're going to do week 1, week 2, and week 6 before they see you again.
Yeah. Especially if it's been going on for a long time, or they're seeing, I mean, I see this in shoulder patients and knee patients constantly, where they're being seen somewhere else, or for whatever reason, I don't know why, but they're just not getting better, and it's getting worse, or it's still like horrible, and they've been in therapy for 8 weeks, and they come see me, and I say, you just back off. Let's just back off for a week. I mean, just quit doing everything you're doing. Like you said, Doc, get some modalities, just let it settle a little bit, and then you can usually start making some progress. But sometimes you got to back up before you go forward.
Rob, why do you think people go with a cold and get a medicine injection for a virus that the antibiotics don't help? That's what they want.
Yeah.
Right?
Yeah.
That's the problem, is they want some, as Doc says, they need something, whether it's medicine or a plan is the most important thing. Instead of just saying, there's nothing I can do, just rest. They need a plan. I agree with that 100%.
In the early days when we were doing our studies on early weight bearing for ACL reconstruction versus no weight bearing, actually we ran some patients who had a normal knee through a ACL rehab program. The ACL rehab program showed about a 17% incidence of patellofemoral pain. So now you're talking about patellofemoral pain of 17% just from the rehab, and patients who have bone, tendon, bone have 25% patellofemoral pain. Well, guess what? They're doing exercise they hadn't done before, So sometimes resting is part of that program.
Yep.
You have to know what the exercise is going to do to somebody before you can say that's the surgery is causing the problem. Sometimes the rehab's causing the problem.
That's right.
No doubt. All right, Timmy. Do you want
All
do you
right.
want to talk about the last study, or do you want me to describe it?
You can describe it.
Okay, so our last study, the effects of the Timmy Tyler twist technique, the quadruple T, versus active release technique on pain and grip strength in patients with lateral epicondylitis. By
This the 4T technique? Is that what we call it?
the
4T?
4T, I'm calling the
I got to give props to
quadruple
Timmy.
T.
I want to give props to Timmy first.
I didn't name it.
I want to tell the story.
All right.
In what year was it, Timmy? 2000.
2000.
We were in a meeting in Prague, and he picks up this rubber bar, and he goes, "I can use this for elbow rehab." And Dr. Yanda, who was on our group, was like, "Oh yeah, that sounds great." So Timmy comes up with this exercise. 5 years later, it's published, and it's just bananas how popular this thing is. It gets picked up by Reader's Digest for all.
That's right. Yeah.
I mean, there's tons of play in this article. And when you look at Amazon.com for the Flex Bar, and you look at the reviews, you can't imagine how many thousands of people that this exercise has fixed.
Yeah, we helped a lot of people.
I always tell people, if this exercise doesn't fix your tennis elbow, number one, you did it wrong.
Mm-hmm.
Number two, it wasn't tennis elbow. It works in 100%, in my opinion, of everyone with true tennis elbow.
Cool.
And I love that story with what Timmy did. He took this idea, he ran with it. It's a landmark study that's helped probably, Timmy, millions of people. So kudos to you for what you've done for tennis elbow. I think it's amazing. So kudos to you.
He's gonna be all nice and modest here on the Journal Club, Phil.
What did you say, Doc?
Was this at a bar?
I'm sure it was.
It was.
Is that the point?
It was at the point.
Yeah, that's not the point, but it was. Yes.
What was the kind of beer they had in Prague, Phil? I don't remember.
Oh, it was Pilsner Urquell.
Urquell. Yeah.
And Timmy, that was your first time ever meeting me, was in Prague.
That was.
And that was when we were in the point, and that's what we did. That's right.
Learned a lot, man.
Nice.
But, Rob, you wanted to tell me a little. So how that came about is that Alfredson et al. Published a study on eccentrics for Achilles tendinosis, and how we can load that up with 2, down with 1. So how are we going to overload the lateral extensor tendon mechanism? We couldn't give people, 10, 15, 20 and progress them with weights to go home with, so they go up with 2, down with slowly eccentric. Mm-hmm. So we figured out a way to do it with the flex bar so that they could actually take it home and do it. And so we'll talk about the article now, but one of the issues was everybody used the yellow flex bar. Not everybody uses the yellow flex bar. You might start with the red flex bar, because the flex bars have different resistance: yellow, red, green, blue. But kudos to Dr. Nicholas and his father that we've been doing eccentrics, Doc. You can tell the story for 20 years before the flex bar came out with the asparagus rubber band. And we put it around the tips of the fingers, and you spread it, and you eccentrically load. Yeah. And Dr. Nicholas's father taught me that one, and Dr. Nicholas continues to use it
really well. We didn't name it after anything, though. We should have.
Yeah.
Nicholas Twist. I like
the Nicholas Bands or something.
Nicholas Band.
All right. So the purpose of this study was to investigate and assess the physiotherapy alternatives for lateral epicondylitis. They had compared between the Tyler twist and active release therapy in patients suffering from lateral epicondylitis. 30 individuals. Group A were taught the Tyler twist technique. Patients in Group B were treated with active release and conventional therapy. And the Tyler twist patients had conventional therapy as well. Total of 30 subjects, I said. Participants randomly distributed into the 2 groups, 15 in each. 4 sessions each week for 3 weeks. Pain was reduced from 5.8 to 2 after the Timmy Tyler twist technique. In Group A, 5.53 to 3.46 after the active release technique. On comparative analysis, post-treatment mean grip strength of the Tyler twist technique group was 24.3. The active release was 21.33. Significance, proving significance at 0.0001. Tyler twist technique was more effective in improving grip strength than active release therapy. That's the study.
All right.
So what do you think?
So you were talking about you had a problem with the was it the dosage or the way they did it? Can you talk about that?
Wait, the doc, did you have a comment before we get started on this one?
Well, you compared ART to the Tyler twist, right? Is ART your standard therapy for lateral companies?
That's point number one. You're exactly right.
So not denigrating the Tyler twist at all, but if you're going to compare the Tyler twist, compare it to a really good therapy program,
That's
because
exactly
the advantage of the Tyler twist, you can go home with it and it simplifies things. So what's the advantage of that versus a really good rehab program?
And I agree 100%. And Timmy, you had in your study, you had chronic elbow pain that had not gotten better, and you did a group that did traditional PT versus a group with traditional PT plus the Tyler twist.
The exact same PT plus the Tyler twist.
That's a proper study.
And yes, exactly. The problem I have with this study is that number one, they didn't do the damn exercise correctly.
I saw that.
And if you look at the figures, I don't know what they're doing with their hands. It's totally backwards. So if you, especially if you look at this, the ending position is like this, Timmy. You know, it's supposed to be like this.
Yeah.
And
maybe he was doing his left hand.
And it was just,
maybe he's doing his tricks on the left.
The problem is another one of those pay for published journals you need to be careful of. Now, I'm not going to say that Timmy's exercise was not better. I think it was, but I think that the editorial work on this was shoddy. I don't like the analysis they did. The power was too low to make the conclusion. They needed 128 subjects.
Did you check? Did you count? 30. You did that? You did the power analysis?
Oh, yeah, I did the power analysis. They needed 128
and subjects. They had 30 or 15 each group.
Right. The effect sizes were very good. They're very large, but you cannot make the conclusions that they made with an N of 30 using inferential stats when they need 128 to make sure they didn't make the type 1 or type 2 errors. So I'm not discrediting Timmy's study. I think Timmy's exercise would blow ART out the water, which with 30, I think it did, but I really I just don't like the fact that they have these full pages devoted to pictures of exercise.
I know. I didn't understand that either. But
that are wrong.
Yeah. Who are we? Who are we though to be?
Well, Phil, unfortunately, a lot of the readers will not know how to do a power analysis, or will not know how to look at statistics in a critical way. And that's the role of the editorial board before they put this out there to make sure that's right. So when I read something and I'm reading the stats, I'm relying on them to have done the job with the stats. And I think you should write a letter to the editor. I'm serious. They need to know that they're not doing the job there.
So that brings back my point, Doc, in the very beginning was we have to, as clinicians, we have to be better consumers because we can't trust what's getting published, not just from the fact of these predatory journals. And I'm not saying that this one is, because it's actually a Springer journal, which is a reputable publisher, but we can't rely ourselves on looking at this stuff. I have to do a better job of educating my students on how to review these articles because I can't trust them anymore. And part of it, and this is a whole other topic, is the fact that we can't get enough reviewers.
Yeah.
Our own journal.
We have that issue.
Incredible to look at. How many do we get, Rob? 100 a month submissions, right? Ashley's just going like 100 articles per month we have to review and find reviewers for. And we try our best, and we have a great editorial board. But with these, the thing I love to do is go, number one, go to the journal website. who's on the editorial board? Do you know any of these people?
Yeah.
Number two, type in their address and put it in Google Maps. It's an apartment in Oklahoma.
A P.O. box. Yeah.
The P.O. box at a UPS store.
Oh, that's good. Hey, we got some questions. Philly, do you have actually a flex bar there in your office?
I can get one in a minute if you need
Well,
one.
Melissa Walker is asking if someone could demonstrate the proper twist technique.
Oh, it's on YouTube.
Oh, okay.
Timmy, what's that? Who was that? Stephanie made that video.
Yeah.
All right, Stephanie. So
Go ahead,
Google
Doc.
it on YouTube.
Go ahead, keep going.
Is he going to get he's going to get maybe a flex
Yeah,
bar.
he is.
Dr. Nicholas, what's your definition? This is from another anonymous attendee. I don't know why these people don't put their names on. Dr. Nicholas, what's your definition of really good PT?
Well, a really good physical therapist is one who communicates issues that the patient has, number one, with the doctor, because they're my eyes. They see the patient 3 days a week. I see them every 6 weeks. So that's number one. Number two, is well-versed in the literature, understanding protocols and why we do each thing. And all protocols are guidelines, and understanding what level you have to reach before you progress to the next therapy. I think that, it's not all cookie book. It's not all cookbook. It's all adjusting to the particular patient's issues. And a really good therapist knows that and observes that. And communicates with.
Great answer. Phil, are you going to show the technique?
All right. So when you buy a flex bar, okay, on Amazon, it comes in different colors. It'd be yellow, red, green, and blue. And what Timmy's study did was he used red and green. At the time, that's all we had. We actually invented the
we just had red and green, and we had red and yellow.
No, it was red and green. We invented the yellow after your study.
Okay.
So, but everyone comes with a package that explains the exercise. Okay. And look, I don't make any money off of this. I'm just showing you. Someone asked how to do it correctly. So if I have right elbow tendinopathy, right? The key that Timmy said, and this is that you can actually use this in any tendinopathy. It's an eccentric stretch. Okay. You shorten it, you eccentric, load it, and then you contract it and stretch it. So if my right wrist extensors are the problem, I'm going to hold this, I'm going to shorten it by extending in a gravity lessened position, not like this, gravity eliminated or gravity lessened. Here, take your other hand, twist it, you load it. So now I'm loading it, and then I bring it here. And remember, my right elbow is the problem. The right is eccentric contraction to a stretch. So the end position, both should be here, right? So one more time, you shorten, load, eccentric, stretch. That's the Tyler twist. And you can
Hey, you did it too quick.
I did it too quick because Ashley's on. Ashley's like, get your ass going. Ashley's like, wrap it up. So she really she panicked.
We still got 6 minutes. There's no rush. We still got 6 minutes.
I'm not trying to stress you out. I'm sorry.
Phil,
Okay.
just
I just thought you missed seeing me.
finish your drink, Phil.
Of course I do.
Finish your drink, Phil.
Shorten, load. Where's the music coming from?
It's Ashley.
This.
All right, Timmy.
Yeah.
Shayna, similar.
Yeah.
Tyler twist is a strengthening exercise. Comparing it to massage technique is not very helpful. Compare it to isometric or eccentric exercises. Do you think the Tyler twist would be more effective than eccentric wrist extension curls, isometric holds, and resisted supination if compared? I'm not sure if she was saying it with that emphasis because it was just typed out, but I was just giving it a little extra.
I think that with eccentrics, as Phil showed you, you're strengthening throughout the range. I mean, you're going to have to do a heck of a lot of isometrics, and then and then isometrics are very subjective. How do you know how hard you're pushing? It's very subjective. So it can be difficult, but certainly there's evidence in the literature for not only the medial epicondylosis, lateral epicondylosis, patella tendinosis, and Achilles tendinosis that slow, isolated eccentrics work 99% of the time if done correctly. So that's I would answer that
whether or
question.
not the Tyler twist works. The Tyler twist is one way you can do it.
Yep.
The use of Timmy's technique, though, is it's compartmentalized. It's easy to take home. It's easy to do while you're working on your desk between calls and your business calls. So that's the advantage. The advantage is not to say would that work better than if it works just as well as that's still a good thing to take it home with.
You can take the bar with you. I thought maybe you guys pissed Phil off for a minute. He just like split on us. Phil, what happened? Hey, Casper, what happened? He left. Oh gosh, Dr. Nicholas and Tim, can you talk about how this year is special for NISMAT? Is this like an anniversary or something? What's going on?
Yes, it is. 50 years ago, NISMAT was founded.
Wow, congratulations.
Story in 1973. My father said, look, we have to have an institute of sports medicine that studies sports medicine and teaches and educates doctors and teaches arthroscopy and all these things that weren't being done. And he had $1 million and he was at the hospital for special surgery. And he said, look, I got $1 million. Let's start this institute of sports medicine. And special surgery said, there's no such thing as sports medicine. So he went across the street to Lenox Hill. He said, look, I'll come and be your chief if you want me, because they were looking for a chief, but I must start the Institute of Sports Medicine to study sports injuries. And they said yes. And he funded, it was the first sports medicine institute in the world, hospital-based, studying injuries, prevention, and sports medicine. So this is the 50th year, and we're going to be celebrating.
Mm-hmm. And back then, Rob, it included athletic trainers, physical therapists, strength and conditioning, PhDs, all of it. It was a
cardiologist, nephrologist.
Yep.
We looked at hyponatremia, training, dehydration, cardiac events. It's quite complete.
Whole deal. Phil, question for Phil. How would Mr. Page? Dominique called you Mr. Page.
That's okay.
Recommend spotting predatory journals. Do you search Beals list? And thanks, Tim and Dr. Nicholas, for great educating us as always.
Yeah,
so
real
Phil,
quick. Yeah, real quick. The Beals list, if you just type it in BEALLES on Google, is a way to start. But I every day, all of us on this call will get emails from these journals asking for us to submit articles. Number one is pay for publish. Now that's not a bad thing in a lot of journals, because there's some. IJSPT, we purposely keep it no pay for publish, simply for that fact that we're not predatory. But we are also indexed in PubMed. The other thing to look for is indexing in PubMed. That automatic, there's probably still about 10% that are not great journals that are still indexed. But when you look at the request, look at the editorial board. As I said earlier, do you know any of these people? They're usually from abstract countries overseas that you've never heard of, and they ask you to actually be on the board.
Yeah. I've gotten
that's my favorite. Would you like to be on our board? Send us your resume, automatic submission, as long as you pay for us to do this. So look at the board, and if it really sounds too good to be true, it probably isn't. Stick with the impact factor is probably one of the biggest things you can start with. But looking at something like IJSPT, again, we don't charge publication fees. We're open access. We're PubMed indexed. Those are the kind of things you want to look for, in addition to the credibility of the article itself.
Yeah, great, Phil. This Ash, I'll just read this one real quick, and then we'll close on this one. This is I think from one of the people that work with you and Timmy, Dr. Nicholas Win Yao Yin. I'm a PT CHT at NISMAT who has been treating lateral elbow pain as per hand surgeon's guidelines It's always great to hear from different perspectives from sports medicine, surgeons, and PT. Thank you both for taking the time. And with that, I would agree. Timmy, thanks for joining us again. Dr. Nicholas, it's always a pleasure seeing you, having you on.
Love being with you guys. The therapists are the best.
Yeah, hopefully we can get you get our meeting back going again, and we can get you out again in the future.
Yeah.
I'll be in a second, guys.
We love having you there.
Yeah. Thanks, Doc. Good to see you, Timmy.
Good night. Thank you.
Love you, Timmy.
Everyone, thank
Love you
you.
guys too. Bye bye.
Take care, guys. Bye-bye.